Hi, everyone. Welcome back. Today, we're joined again by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the state of Utah. We're going to be talking a little bit about case counts and trends in our hospital systems first. The state has a total of 50,557 cases. Our daily case count as of yesterday was 376 with a positive rate of over 8%. We have a total of 403 deaths in the state and 3,015 hospitalizations. Eddie, will you give us a little bit of a rundown on how we're doing from a hospital capacity in the different regions as well, and how we're kind of doing as a state overall?
Yeah, we've certainly improved from where we were in kind of early and mid-July and late July, and we've seen a nice decline in cases through the month of August. And that decline in cases is also paralleled by declines in Arizona and Texas, a little bit in Georgia, same thing with California and Nevada. And so it's, we're going through this as many states are going through this as well to kind of get over that pretty significant spike we saw really starting after Memorial Day. So we're definitely getting better from a total case count standpoint. It looks like based on our data here within Utah, we may now have started to kind of plateau at a new kind of baseline level of cases right around 300 to 400 cases per day for the past kind of 8 days or so. We'll see where that goes. I mean, clearly going back to school, University of Utah opening, BYU opening, these are things that could lead to, more cases and increase in case counts. It may not have as big of an impact on our hospitals because we see more transmission in the 18 to 25-year-olds. That may not lead to as much severe disease, but it's something we're going to have to watch really, really closely. And ideally, we'd like that number to continue to go down, back down to levels of 100 to 200 cases per day, especially as we go into winter. In terms of what's the impact on the hospitals, we've actually seen a significant lessening of our census of COVID-19 patients within Intermountain Healthcare. Back in July and first part of August, we were running a census about 170 patients per day across our system with documented COVID-19 being admitted for COVID-19 pneumonia. That number now is almost halved, and so we're now at about between 70 and 80 number of cases per day in our hospitals with COVID-19, which has allowed our hospitals to kind of take a sigh of relief and kind of catch our breath a bit from those really significant numbers that we were having earlier. Just an example, at Intermountain Medical Center, we were running a census about 50 to 55 patients in the hospital at one time with COVID-19, and now that's down to about 25 to 30 cases, which is still a lot, and still a lot of disease and suffering, but it's certainly better than it was, and has allowed our ICUs to kind of, take a little break, give some of our caregivers a little break to kind of regroup a bit. And so that's been nice, for us and for clearly the patients. And so we hope that decline continues, and we hope to have that kind of pressure taken off. I think there is, we definitely see kind of regional differences in where this pressure has been removed. Intermountain Medical Center serves mostly Salt Lake County and the surrounding areas. If you look at, our Utah County Hospital, Utah Valley Hospital, they're still running a census that's pretty high for them. They had 16 patients admitted right now, about 10 under evaluation. That number hasn't changed a whole lot from, the peak of the epidemic in July and early August. And when we look at the state's numbers on the state website, you see that Utah County has declined a little bit, but not to the extent like Salt Lake County has. I think Utah County just instituted a mask mandate as of this morning. The city council approved that, and I would anticipate that that's going to, certainly improve their numbers over the course of the next couple of weeks, especially as their schools and colleges go back online.
Yeah, I think it's interesting to note that Salt Lake County put the mask mandate into place. I think that was the end of June. So it's been a couple of months, and we've definitely seen that decline in cases, which is great. And I don't know how true this reporting was, but I saw that 90% of Salt Lake County is starting to wear masks. And I don't know if that's people self-reporting or how that is, but that's great to hear that people are actually doing it. So hopefully that mandate in Provo kind of helps, or Utah County starts to help their caseload and case count. So it's great to hear that things are moving in the right direction. I want to talk about something too related to vaping or smoking or high risks related to COVID. There's been a lot of information out there about how the connection between COVID or vaping and COVID can actually increase your risk of the type of symptoms that you get. What do we know about this, and why is it so important to stay healthy during this time?
Yeah. I think we're learning a lot more about this now, and there's been some recent reports. One out of our group here with Intermountain Healthcare, led by Denitsa Blagev, who's one of our pulmonologists and one of the experts in vaping-associated lung disease, or EVALI. Another report out of Stanford as well, showing that among teenagers that vape, they're more likely to get COVID-19. And whether they're more likely to get symptomatic COVID-19 versus asymptomatic, I think is yet to be kind of teased out, but are more likely to get sick from COVID-19. And I think it just speaks to the fact that, if you have comorbid conditions, you're more likely to have a worse time with COVID-19. So whether that be you have heart disease, or you've got lung disease due to smoking, or that you vape, you're more likely to get severe disease with COVID-19. So it just speaks to the fact that do everything you possibly can to remain healthy. And if you have diabetes, control your diabetes. If you smoke, try to stop smoking, or at least reduce smoking. These are all things that we all can do to lessen the impact on us if we were to get infected with SARS-CoV-2, the virus that causes COVID-19. And so I think vaping is just another example of that. We have to do what we can to remain healthy. And clinically, it's really pretty challenging to tell the difference between COVID-19 and the condition we call EVALI, or vaping-associated lung disease. They look very similar. They can cause, severe problems with oxygenation, a severe pneumonia. There are some subtle differences between EVALI, the lung disease associated with vaping, and COVID-19, but they're subtle. And so it's a challenge for clinicians to pull those two apart. But it's something that we're becoming more and more aware of now as we're seeing more COVID-19 and getting more comfortable with EVALI. But really important, especially as kids are going back to school and high school and college, where a lot of the vaping takes place, is really now is the time to stop because of its association with COVID-19.
And along those same lines too, I think it's important to think about what you're doing when you go back to a college campus or even high school campus. Are you gathering in close groups now? Are you hanging out with your friends more? Like, what can you do to really mitigate your risk from getting sick? And if you live with your parents perhaps and you commute to college, like what kind of precautions are you taking? So I think it's important to know that this isn't going away, even though we're doing better, and we need to make sure we keep up kind of what we're doing so far. So
yeah, you're absolutely right. I mean, now is the time for vigilance. I think we kind of saw that in the summer in May when we were doing great, and then we kind of let down our guard and we saw this big spike. Now that we are improving our case counts, the last thing we want to do is we're going into Labor Days to see a big spike. And, on top of that is we're now going back to environmental settings that could lead to significant transmission. College, for example, what a great place to spread an infectious disease, right? You're now taking young people that love to socialize, go to dorms, go to parties. This is a recipe for COVID-19 transmission, if I've ever heard one. And so, yeah, it is really important to be cognizant of what can I do to decrease transmission of this infection? Because what we know is that when we see transmission in schools, whether it be in elementary school or a college, that leads to community transmission. And I think your point of, living with your parents and going to college is a great one, and a great example of how transmission on a college could affect community transmission. Because if you were to go home after spending, time with your friends at college without, appropriate face masks or social distancing, and then you go home and you transmit it to your parents, you can see how that cycle continues about then getting into the community outside of your college campus. And it's really, really important to be having a plan and talking about this with your, with your social group.
I want to talk a little bit about a misconception too that we keep hearing. People keep saying, well, why do I have to social distance if I'm wearing a mask? And why do I have to wear a mask if I'm social distancing? There's this not correlation between the two for people, that sometimes both of them are actually needed, or needed as much as possible.
Yeah.
So why is one more important than the other? And do people really need to wear a mask if they're 30 feet apart from each other?
Yeah. I mean, if you think of the hierarchy of public health interventions, social distancing is the best, right? So if you can stay home and not see other people, you're not going to have transmission of the virus. Okay. If you can engage with your community and not come within 20 feet of somebody, this respiratory infection is not going to be transmitted, regardless if you wear a mask or not. It's not possible to transmit over that type of a geographic space. And so, yes, social distancing is, by far the most important. And if we can limit the number of interactions we have with people, that's going to decrease transmission. Now, when you can't social distance, that's when you wear a mask. Okay. And so, yeah, I agree that there is a misconception there. And I'll see somebody completely by themselves, not near anybody else, wearing a mask. And, that's great if they feel comfortable doing so, and that's, their personal choice. But, that's not the instance where you have to wear a mask. You have to wear a mask when you can't social distance, or you're not consistent in your social distance. Schools is a great example for this. Kids may say, well, why do I need to wear a mask if I'm 6 feet away from people in my classroom? And the issue is that that's not consistent. You're not always 6 feet away from your classmates in a classroom. So when you can't consistently social distance, that's when you wear a mask. But if you're going to go and, get together with a friend at a park and you both are 10 feet away from each other, you can take your masks off because you are consistently, apart and are not going to transmit the infection. But when you can't be consistently socially distanced, then it's really important to wear the mask. And, the science behind the mask use is getting to be kind of just, very, very clear. I don't think we need to belabor this point, any more than we already have. There's plenty of examples of, instituting mask mandates and case counts going down without any change in kind of physical distancing or movements of communities. Salt Lake County is a great example of that. But even look at, our neighbor to the east in Colorado. Colorado never really had a big second spike. They had a bigger spike initially, but they never had a big spike like we had. And that's most likely because they instituted a mask mandate that is followed across the state of Colorado. And if you go to Colorado, everybody's wearing a mask. And so I think that just shows you, what masking can do. It's a great example of just, somebody or a state nearby. So yeah, masking works. It's that part's clear. It's just getting everybody to do it.
I want to talk about that 6 feet number too. Someone recently said to me, well, I don't know if I believe this whole 6 feet part. How do we know anything about the length that the virus can actually travel? What is that based off of? Because in my knowledge, it's based off of a sneeze. And I've always heard since I was a little kid, a sneeze can travel up to this many feet.
Yeah.
But what is that based off of? And where did we initially get that sort of data from to begin with?
Yeah, so there's a number of studies that look at droplet transmission travel with normal speaking, singing, and sneezing. And the travel of these droplets that carry SARS-CoV-2, these big kind of water-based droplets, drop off dramatically at 6 feet. And so, 6 feet is just kind of the point where the vast majority, 95% of the droplets will have dropped off and fallen to the ground and not remain in the air. And so 6 feet is based on those studies of, droplet transmission. And it's a pretty well kind of regarded kind of distance just based on the science of droplet travel. Yeah, I mean, and I think it should be noted that in certain instances, you're going to have transmission farther than 6 feet. And we've seen this, right? We've seen this in choir practices where you've had very significant transmission with over 50% of the people getting infected. You've seen this in close quarters with poor ventilation, with people not being masked. And so there are instances where you're going to get longer transmission, right? And this isn't just black and white. 6 feet's not a magical number. It's all dependent on, the environment you're in and what you're doing and the number of people. And so if you're in a small space, even though you're 6 feet apart and you're all singing, like there's going to be transmission past 6 feet. But if you're outside, or in a place with really good ventilation and you're not undergoing those kind of activities that cause a lot of transmission, 6 feet is a great marker to stand by.
We just got a question about school. This person wants to know how long you anticipate it taking to see if community spread rate goes up with schools opening. And
Yeah.
I know that like Salt Lake County itself isn't opening at all, I do believe, for the fall semester, but in other counties, what's like our lifespan of when we should see if we're doing well or not?
Yeah, and it's something we're watching really, really closely. So keep in mind the incubation of the virus is about, on average, it's 5 to 7 days, but it's up to 2 weeks. And so we really start kind of getting the first glimmer of data 2 weeks after a transmission event. And so that transmission event, we're just going to say is going back to school. So if you want to say Granite School District or, whatever school district you want to look at and look at the surrounding communities, you really aren't going to get any idea of transmission until 2 weeks later. That's really when you start getting the first idea of, are we seeing an increased number of cases? And the public health department is looking at this really closely. They're tracking outbreaks on their website. But really good question from the viewer. 2 weeks is when you'd start to think about when you're going to start seeing increase in cases. And this is what we saw, when we looked at Mother's Day and looked at Memorial Day. It was really 10 days to 2 weeks after that when we started to see this increase in case counts. And then it's usually 10 days after that where we start seeing increase in hospitalizations. So keep an eye kind of in the next week or so that comes. And you're right, Salt Lake City is going fully remote for the first quarter. And so we'll start to see, after that first quarter. And what's going to be challenging then is that we're going to have co-circulation of other respiratory viruses in the fall.
Before we get to that, is it also possible that we might have a delay of data if people aren't reporting that they are sick or if their children aren't actually getting tested? Is there any way for us to truly know what's going on unless people actually go get tested or report that they're feeling sick at all?
Yeah, getting tested is by far the best way. We really want to encourage testing if you're sick or you feel you have symptoms of COVID-19. That is the best way for us to track transmission and really get our hands around what is the impact of school. And so we are in a really good spot here in Utah in terms of our testing capacity. We have got really significant testing capacity. It's really, it's a luxury we've had in Utah. We don't realize it's a luxury, but when you compare it to other states, you're like, oh, yeah, that's different. And so with 2 big labs, three, ARUP, and then Intermountain and the Test Utah, we're in a really good spot in terms of being able to accommodate testing. Our testing turnaround at Intermountain now is about, the average is 24 hours. And many times it's less. And so if you have symptoms, it's very, very important for somebody to go in and get tested, whether it be through a drive-through site or one of our urgent cares or within a University of Utah drive-through site. Doesn't matter to us, just get tested because that's really going to allow us to get a handle on how effective are these school-based mitigation strategies. And that's going to inform how we're going to do this as we go into the winter. So yeah, I'd highly recommend getting tested. And I think our testing procedures are likely going to get better here very shortly. And moving to saliva-based testing would prevent somebody from having that swab stuck up their nose and make it just easier for the person getting tested and also the testers, because they don't have to wear all of the airborne transmission garb. So look for that to be coming hopefully in the next few weeks.
Yeah, I keep hearing from people too that I'm not going to go get my child tested because I don't want to pull them out of school, which goes to my next question kind of about this cultural shift. And then we'll talk about the flu for a bit. But a lot of people, it feels like, are going back to these pre-COVID habits of hanging out with their friends, if they have a cough, going to work. Why is it so important that if you're sick, you stay home from school, work, wherever it is that you normally go, especially as we go into this flu season?
Yeah.
So if your child does have these symptoms, why is it so important to keep them home and make sure that they're not spreading it around?
Yeah, this is this point just cannot be understated as we move into the cold and flu season, is that if you're sick, if you have cold, nasal congestion, sore throat, whatever it might be, that you do not go to work or to school or socialize until your symptoms are improved, if not gone. We've seen that COVID-19 can have a myriad of symptoms. We used to think that COVID-19 was just cough, shortness of breath, and fever, right? That was the initial report that we were looking for. But now as we learn more and more about COVID-19 and we see more and more people with COVID-19, we realize that, COVID-19 can cause pretty minimal and mild symptoms. So mild COVID-19 can include nasal congestion. It can include sore throat. These are things that we all deal with on, every single winter. I don't know how many, I haven't had a cold that hasn't been associated with a sore throat, right? And, as we move into the winter months, like that could be COVID-19. And so, our culture before this was a more kind of selfish culture. And I'm saying that from somebody who was part of this, was that your thought about, do I go to work or do I go to school, was driven by, can I be effective at work or can I effectively learn at school? That was the decision that you would go through and say, if I can be, I'm going to go to school and I'm just going to suffer through it. And healthcare workers are notoriously terrible at this. We would come to work sick all the time. But now that whole kind of paradigm has changed, and we have to think about the transmission to our coworkers and to our students is the primary reason for not going to work or school, not about whether you can effectively be there to work or to learn. And so we have to switch that paradigm on its head. And if you are sick, you need to stay home. And I think this message needs to get to both employers and school, because many people send their kids to school because they don't want to take off work to stay home, or they go to work because they don't want to take a day off. And that whole thing has to change for employers and for schools, because staying home when you're sick is the right thing to do, and we have to make this easy for people to do it. And so telecommuting, continuing to focus on that, working from home, and understanding that, hey, this is going to be an issue as we go into the cold and flu season, is just paramount for employers to understand and to make accommodations for their employees.
I know a lot of people who have never missed a day of school or work. So yes, if you're feeling sick at all, yes, it's very important. I want to talk about the flu now. So the flu season is coming up, where it's crazy. We're almost in September. It's going to start snowing here in Utah soon. What do we know about this upcoming flu season from the Southern Hemisphere, and what can we take from that to start to apply it to what we can expect us to experience this fall?
Yeah, so you're absolutely right. So starting next month, you can get a flu vaccine, right? So that just kind of the signal for all of us in healthcare, like, oh, it's coming. The way we look at flu and try to predict flu here in the United States is to look at what's going on in the Southern Hemisphere in terms of flu activity. And we use that, whether it be the strains that are circulating or just epidemiology, to then look at how we are constructing our vaccine here in the Northern Hemisphere or preparing for influenza. When we look at, right now, Australia has some very good data on influenza. And the good news is that it's been a really mild flu year in Australia. And you have to ask yourself, well, why is that? And if you think about the mitigation strategies that we've put into place for SARS-CoV-2, social distancing, masking, and hand hygiene, those are the same mitigation strategies you put in place for influenza or other respiratory viruses. There's nothing special about these strategies in SARS-CoV-2. This is the strategies you use for reduction of respiratory viral pathogens. And so most likely what's happening in the Southern Hemisphere is the masking and social distancing and hand washing is not only reducing SARS-CoV-2 transmission, but it's reducing influenza transmission. And so we really hope, we have to continue this emphasis on social distancing in work and school and social, and also masking when you can't socially distance, because that's also going to impact the influenza, epidemic that will come them as having a severe COVID-19 season, that's going to incredibly stress and tax the healthcare systems across the state of Utah and across the U.S. And the thing is that we have something that can prevent severe flu, and that's as simple as a vaccine. And so there isn't a more important time to get a vaccine than this fall. And the whole reason is to decrease severe influenza. And there's a lot of bad press about the flu vaccine. But what we know about the flu vaccine is it may not prevent somebody from getting influenza, but what it does and does well is it prevents severe disease due to influenza, which is what exactly we need to prevent. And so this is the year that everyone needs and absolutely has to get a flu shot to really help us kind of take that off the table. And I think with good flu vaccine uptake and social distancing, masking, and hand hygiene, I think we're going to have a very kind of low flu year. In addition, we're going to have less transmission of other respiratory viruses that cause the common cold, and otitis media and sinusitis and all those things that the upper respiratory viruses cause.
And from an Intermountain perspective, I know that we are going to be having drive-through flu shots happening. There'll be more coming out on our social channels and our website about that in the next couple of weeks. But like you've said, September is flu shot month, or at least we start there. So once we have schedules of locations and all of that, we'll get that information out to you guys. But Eddie, last question for you. I just want to get a quick update on our clinical trials and some therapeutics that we've been using, convalescent plasma, kind of talk a little bit about the treatments we're using for COVID-19 patients right now.
Yeah, so the big one in the news, as we saw on Monday, was about convalescent plasma getting the FDA approval for emergency use authorization, or an EUA. That was based off the study that was done at the Mayo Clinic in Rochester that just looked at a large group of patients, 30,000 patients that received convalescent plasma, and compared those that received kind of high titer, high concentration antibodies to those that received low concentration antibodies, and compared those that received it early versus late in their symptom onset. And it appeared that people that received high antibody titers did better than low antibody titers, and people that received it early did it better than people that received it late. And again, we've talked about this, I think, last week, and the fact that this was not a randomized controlled trial. Okay, this was a very large cohort study that the FDA used to say, hey, I think this is enough for us to go ahead and release an EUA, which allows essentially anybody who wants to use convalescent plasma of people that have recovered from SARS-CoV-2 as a treatment. You know, I think from an Intermountain standpoint, we've been using convalescent plasma routinely in our patients, and we've been trying to use it early. But we are all, you know, anxiously waiting randomized controlled data to really tell us whether or not this has a big impact. I suspect it will have an impact, and because if you look at the way we treat other viral infections, we use essentially the same technology, but we haven't had the RCT, the randomized controlled data, to really inform that. And that's what we're really waiting for. And the EUA, unfortunately, makes this a little bit harder, because now, you know, most people that are getting admitted to the hospital will get convalescent plasma. So it makes it harder to really study this effectively. What we are really excited about is something called monoclonal antibodies. And so in convalescent plasma, you're taking the plasma, which is essentially the liquid component of blood, without the cells, you know, without the red cells, the white cells, and the platelets. That contains antibodies against SARS-CoV-2, but it also contains lots of other antibodies as well from that person. And the antibodies to SARS-CoV-2 may be high levels or low levels. Now what people are doing is that they're actually manufacturing the antibody specific to SARS-CoV-2 spike protein and developing that as a therapy. So that's called a monoclonal antibody. So one clone of an antibody that targets SARS-CoV-2, and can administer that to patients when they come into the hospital, or if they have high risk features that could lead to hospitalization. Those studies are ongoing through the NIH and through other groups, pharmaceutical companies, that really have you know, us excited as being a very good therapeutic for this, especially if used early in the course of disease. And that's kind of coming off of the science of convalescent plasma. And so we're excited for those. We're starting trials for those within Intermountain. The University of Utah is starting trials for convalescent plasma. And so you're going to see more and more science come out of this for that. Remdesivir continues to be used widely across, and we've had good supply of that. And same thing with dexamethasone in terms of our severe disease requiring high oxygen needs, and that continues to be a therapy. So research continues to be going full tilt in terms of therapeutics. And then the vaccine work is also continuing as well. We can talk about that if you'd like.
Yeah, can you just give an update really quick on how the country is doing as far as a vaccine? I know that it's been moving into other phases for the public to now start being involved. Where does the vaccine stand? And are we still on that timeline for a more general public release sometime early next year?
Yeah, so 3 big trials have started, phase 3 trials that have involved either US-based manufacturing or US-based sites, one by Oxford Vaccine and AstraZeneca, another by Pfizer, another by Moderna, which is a company out on the East Coast. Those studies have started. In fact, there's a trial site here in Utah on the Redwood Road that is enrolling patients for those. And those just got started at the end of July. And so they're now in this enrollment period. Many of these studies are trying to enroll up to 60,000 patients. I mean, huge numbers of people trying to get enrolled into these studies. And that enrollment is going on right now. We're going to see more and more of these phase 3 studies coming, whether it be, other big manufacturers, things like Novavax and Johnson & Johnson, and they're all have vaccines in the pipeline and will be starting phase 3 trials most likely in the fall. We're going to see more and more of these. I anticipate that, the FDA has said we need at least 6 months of trial data to show whether or not these vaccines are effective. And I hope that we stick to that. The last thing I want us to do is take any, shortcuts as it comes to safety in terms of giving an EUA for a vaccine or emergency use authorization for a vaccine. So what I'm hoping is that we'll get good trial enrollment and that we'll see these studies running through January, taking a pause, evaluating the data, submitting an application to the FDA, and then an FDA decision coming about an EUA after that. So, which would probably come March or April, I'd imagine, at the earliest. And this, Amanda, is if the vaccines work, which is, it's an if. Most vaccines fail. These have been moving very, very quickly and have shown promising phase 1 and phase 2 trial data, which, makes us very optimistic. But we have to be realistic and say, hey, most vaccines fail, and we have to really have a close eye on these. And you're going to see, I think, vaccine approval kind of be rolling through 2021 because we're having all these different companies and different platforms come up for vaccine trials, which I think is a very good thing because then our probability of one of these or many of these working is much better. So I think we're still on track, and I really hope that we aren't going to see any pressure to get one of these vaccines approved early. And that we actually go through the minimum amount of time that we need to get it approved. And also keep in mind, it's kind of a catch-22. We want our community to succeed, right? We want case counts to go down. If case counts goes down, that makes showing the effectiveness of a vaccine harder, and that may push us out even longer. And that's what I hope happens, right? I hope that our communities continue to have decreased cases, and it makes it really hard on the clinical trialists to show an impact, because what that means is that people aren't getting sick from COVID-19 and we're doing community-based prevention methods and it's working. And if that means we don't get a vaccine until July, August of next year, great, because that means that we've effectively controlled the virus. But that's something we have to keep in mind and will impact how soon we'll get data from the vaccine trials.
That's an interesting thing to think about, the catch-22. I've never thought about it that way. Eddie, thank you so much for joining us this week. We really appreciate the update. And if you guys have any questions about COVID-19 and would like to get screened, you can call our COVID-19 hotline at 844-442-5224. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. Again, Eddie, thank you so much, and we'll talk to you next week.
Sounds good.